As we move forward, we shift our lens from metros to Tier 2 India, from institutional hubs to rural and semi urban landscapes where fertility remains a deeply personal, often stigmatized subject, and access to quality care is still a challenge. Our next session is titled IVF for Bharat, and it asks, how do we truly decentralize fertility care? Can we deliver world class outcomes outside of metros? What are the infrastructural, cultural, and financial gaps that we must bridge? And how do we ensure that in this expansion, no one is left behind? May I now invite our panelists for this session? I request you to please join me on stage as I call out your introductions. We begin with Dr. Indrani Lodh, Director, Urvara IVF, Kolkata. Dr. Lodh has been a pioneer in advancing women's health in Eastern India. Her work combines community outreach with clinical excellence, making her a strong voice on regional IVF models rooted in empathy and ethics. Ladies and gentlemen, please bear with us while we quickly set up the stage for the panel to come, and I will continue to introduce our panelists in the meantime. We have Mr. Gaurav Singhai, COO and co-founder, Gunjan IVF World. With multiple centers across Tier 2 cities in North India, Mr. Singhai brings a strategic operations lens to fertility access. He understands the real-world logistics, affordability models, and behavioral shifts required to build trust beyond metros. We have Dr. Sohani Verma, Senior Consultant, Apollo Hospitals, Delhi. A senior figure in reproductive medicine, Dr. Verma has been advocating for accessible fertility services, public awareness, and gender-sensitive care. She brings both legacy, experience, and progressive ideas to this panel. We also have Dr. Keshav Malhotra, Director and Chief Embryologist, Rainbow IVF. One of India's leading embryologists, Dr. Keshav combines lab leadership with a passion for bringing international standards to local IVF centers. His perspective merges science, youth, and system-scale vision. We also have Dr. Sudha Prasad, Director and Senior IVF Specialist, Medical Institute of Reproductive and Sexual Health. Dr. Prasad is a highly respected name in reproductive health, known for her strong academic background and work in building affordable care pathways for underserved populations. To moderate this session, we have Dr. Narendra Malhotra, Managing Director, Rainbow IVF. Dr. Malhotra is not only a veteran in reproductive medicine, but also one of the most credible voices in national ART policy, training, and public education. With centers in multiple Tier 2 cities, his leadership in this session will bridge ground reality with strategic insight.
So, very good morning to all of you. It's indeed a pleasure to be here in this very, very well organized 6th India IVF Summit and Awards. And we all know that 25th of July, 11:47 p.m., the whole scenario of infertility changed, and probably we conquered a major part of infertility. Can I have the slides? So what we are going to talk today from these experts, we have Gaurav, we have Dr. Sudha Prasad, we have Dr. Keshav, and we have Dr. Indrani Lodh on how to take IVF for Bharat, and how, can we have it here also? So they can't see the slides otherwise. So expanding the access to Tier 2 and rural India. So we have these panelists which you've already been introduced to. IVF in rural versus India. Dr. Indrani, what are the biggest barriers to IVF awareness and access in the 2-tier and in the rural India? Yeah, the mic is on.
Good morning. Happy World IVF Day to all of you. So I think the biggest challenge is that there aren't enough IVF clinics in the Tier 2 cities, leave the rural India.
We just
and
heard
India
mushrooming, we just heard from somewhere. It's mushrooming and you say they're not enough.
India is 80% rural and 20% urban.
In the rural part,
yeah, and all the growth that is happening right now is happening around the metro cities and the other big cities mostly. But tier 2 and rural India is still far away from what we need and what we have.
Anyone else wants to add, Dr. Sudha?
Hi, thank you for calling me. So I just want to say first that how much is the education? If you go to the village, if you have really gone to the village, you should know about it. That people do not know there is an infertility treatment. This is the number one thing, because uneducation.
So your first thing is lack of awareness.
Totally awareness is not there. They do not understand that this disease is also treatable. And there are so much of myth about it, stigma, taboos of the society, that they do not understand that this will be declared in the society that I have no child and I have to get treatment about it. So this is very much important. And another thing, when you go to the village, I don't know how many of you have gone to the village. I go to the village and I see there is no electricity. Even this
So
mushrooming
infrastructure is
the
a
infrastructure comes late. Normally electricity is not there. So IVF labs and the OT requires a real electricity and it should be properly supported.
Stabilized and everything.
So it is not there.
Gaurav, what about you? How do you think, are these points, of course, very valid points?
In addition to what ma'am has said, awareness, infrastructure, lack of infrastructure, there are 3 A's that are very, very important. The first is the affordability, the second is the availability, and third is the access. Now, affordability. Typical IVF cycle typically costs 1.5 to 2 lakh rupees. Hamara to per capita income is 1,14,000 only. So the poor families are spending 1.5 years of their earning for one IVF cycle. So affordability is a big question.
So cost is the question.
Yeah. Second is the availability.
Because Dr. Indrani said it's not available.
And then the access.
And then people don't have access.
So when people come to our centers from rural places, they face a lot of hardships. It takes time, then accommodation issues and everything. So it's not accessible to them also right now. Even the basic infertility care is also not available. IVF to abhi dur ki baat hai.
Dr. Keshav, what do you think about
I think
this?
that's where insurance has to play a very big part in the near
Some
future.
insurance has to be there for rural
Because,
people or for everyone. Yeah.
It has to be there for everyone, because now we just heard the previous speaker speak about how our fertility rates are declining. We're already at 1.9. And unless and until the government makes a policy change and includes IVF in their insurance policies, I think we will further decline. So that's something that we really need to speak about. I think Vikas is also going to touch upon it from Safety. They're launching something. So, yeah.
So anything else in the rural, apart from these points which they said? Awareness, cultural stigma, misconceptions, low availability, fertility care, the 3 A's, and of course the cost. Superstitions, the misconceptions.
Superstition, yeah, it prevails very much in the rural India. They think infertility is a curse.
Go to a fertility doctor who will do all
No, they think it's a curse and they are being punished for their karma. Not in this birth, maybe in the previous birth. You know, all that is there.
I think that's also
and
there.
fertility babas.
That's also there in tier two cities where.
And so the first thing I think we need to tell them that infertility is a disease. It's not a condition. It's not a curse. It's not a superstition.
So thank God WHO
So that's,
is
I think,
recognized
yes,
as a disease.
and yeah, WHO has
Otherwise,
recognized.
I just want to add, even the infertility is there in a couple, always the blame goes to the female.
Yes.
And
that's right.
finally, with great difficulty, great counseling,
You are
the
able to-
male partner comes and he is azoospermic. So we do not know exactly.
So
the
Dr.
reason.
Keshav, the next direct question comes to you. Is cost the main hurdle, or is it the availability of the trained professionals like you in the non-metro cities? And you would not
think-
like to be in a rural area, people like
No,
that level?
honestly, we have gone to so many smaller cities and established clinics there and worked there. So I do feel that is somewhat being taken care of, but cost is something which is probably one of the bigger hurdles. UNFPA just came out with their report for 2025, which lists as the real fertility crisis being in India. And what they label in their report is it's the housing crisis, it's the salaries, it's the inflation. These are all factors that are actually determining whether people can even afford to have a child, let alone go through a process like IVF to have a child. So there are lots of other things that we need to also take care of as a country and not just focus on IVF itself.
Anyone wants to add that? Cost or trained professionals?
I just want to add here,
Yeah.
when in Maulana Azad Medical College in 2006, I started the IVF in a public sector. So there was lots of hue and cry that why it really required. I have to go so many times to the secretariat to catch the people there, that this is a problem. You sit in the infertility clinic and see how people cry, how women cry there. So sensitivity, I got it. Finally, I got the IVF center, and the government said, okay, we will give the free IVF. When I have given the cost, then they said, my God, all Maulana Azad fund will go to the IVF only because it is so costly. So finally, gonadotropin was is excluded, and everything, all media, disposable, consumable were given by the government. But there are few numbers in the government sector which can really give the support to.
So that's another challenge, to have an IVF center in the government college. It's now compulsory by the NMC, Indian Medical Council, that everything, for every medical college to have a center so they can train students. And finally, the government is planning to have it in the district hospitals also. But the problem is of the media, the disposables and the procurement.
The tenders.
The
It's
tenders
really difficult to run an IVF clinic. I think ma'am will agree in a government setup, because an IVF process is time bound and we can't really afford on not having the right media at the right time, not getting injections at the right time, not getting access to embryologists or critical equipment which is not made in India. There is a cap.
25% of the equipment should be made in India.
It is actually very difficult. So till the government strengthens the public sector, IVF is going to be dominated by the private sector, and it's much needed.
So we now have almost 500-600 medical colleges have gone into the rural, and that's where IVF needs to go to provide rural care. So we must understand that trained personnel, infrastructure, and cost are both critical to it. Dr. Sudha, how can the government schemes, insurance programs, Ayushman Bharat help? See, Maulana Azad, the Delhi government was very big-hearted, and they said free IVF.
With great difficulty.
With great difficulty.
Because when I took this
we know,
proposal,
we struggled with you. We went to the
so
government
they said,
with you.
my God, you need a belgadi or ek hawai jahaz bhi. How this is possible? This was the terminology used for me.
So what do you think the government should do? Bring this into all the government free schemes, health schemes?
See, in government policies are there, but the funds are in Ayushman and Janni Suraksha and all those things. I tried my best to get this, but it is so difficult because infertility is not added in that list. Yeah. This is number one problem, because they think without this, people can survive.
We are already overburdened with children.
Overpopulated
Should we have
area.
more children or not?
Because I remember in 93 when I went to Baylor University, they said India wants the IVF center. Why? They are highly populated.
Or add karoge population.
So in India, what they will answer about it? They had this kind of question from me. So this is another problem, because they cannot. So this is Janni Suraksha. Number one, we should add the infertility also in that list. Then only we will get the part of the thing. If some government has paid about 65 to 80,000 rupees, why only the government person will get? Because they have get the reimbursement.
Should be open for everyone.
It should be open for everyone, and all private centers should be recognized for this IVF. And people should get from there that they should sign it. Yes, of course, under the ART law, they should work.
Gaurav, your thoughts on this? Ayushman Bharat, should it
Yeah,
cover
yeah.
IVF?
I'll talk.
5 lakh,
First, I'll talk about the concept of population explosion is an outdated.
Yeah,
I am not saying. Sanjeev Sanyal, the principal economic advisor of the Prime Minister, has said, if we take out UP and Bihar population growth, then India's fertility is falling really rapidly. So it is propped up to 1.9 thanks to UP and Bihar. Now, so first change in the policy makers has to be that we are no longer reaping a demographic dividend because we are already, the peak number of babies have already been born 15 years back. Even Pakistan and Philippines are younger than us now. And in 2050, our demographic dividend is going to stop giving us results.
be like Europe
Yeah,
or
yeah.
something.
So the first change the policy makers have to see is that population is no longer a burden, it's an asset. So everything has to start from there. Things like Ayushman Bharat and all, of course, they should be included so that the poor families can get some support. Yeah. So yeah, government should
So
now
we have to
support.
understand that when we look at infertility, and on the other hand, you look at cardiac disease, hypertension, renal disease, and diabetes added together, the infertile patients are much more than these diseases. And there's a lot of money being pumped into these diseases and the research and the free treatments rather than into infertility. So that is what someone has to make the government understand. So Gaurav, while there aren't any, see, the government does not have any advertised government schemes for IVF insurance. We from ISAR have this thing for two cases of we're deservable to do free IVF. So the ISAR centers can opt for the ISAR scheme, Dr. Sadhna Desai's scheme, and where can provide. So it's one or two, but it is still there.
No, there are some states also that are
So,
now
sir, yeah, that's,
working towards
so
it.
Tamil Nadu is one of them.
Goa has
Goa
a
is
scheme.
one of them.
Even Maharashtra, Parsis for the community, they have a scheme.
Subsidized fertility care for the Parsis, free first IVF cycle by ISAR, and that could be the good side. Like in Israel, it is totally free. So Gaurav, now to you, what are the technical challenges and the medical infrastructure for setting up a IVF unit in a rural? I mean, can you have a lab like this in say Achnera or somewhere like that?
If you see the cost of setting up a lab, right now it is anywhere between 2 crore to 3 crore. The
So
cost
affordable?
is, yeah,
Not-
the cost is high because there is so much of import component in the setup of the lab. So if we are able to produce good quality equipments in India at a lesser rate, then the cost of setting up labs will come down, and in turn the cost of treatment will also come down. So indigenization or Make in India has to come into our sector also.
So Make in India,
Make in
is
India,
the answer.
yes.
Dr. Keshav,
Yeah.
what about labs?
I still feel that access to laboratories is still doable because we don't need such a big laboratory. Even though this is our lab in Agra, we don't need such a big lab for rural setups. Smaller setups can actually work, and they can produce the same amount of results, or good results for such setups. I feel that people are unable to step into that market because they are unsure whether patients would be able to afford. And unless and until that is solved, people will not enter into the rural market, and the access would still be limited.
But still, for a lab, you'll need backup.
Yes,
you can't
like
do with one
ma'am
incubator.
mentioned,
because the
you
power
need
failure-
electricity.
Lots of things.
There are
Not-
lots of issues.
Not only the lab will be made in a rural area, in some village, and it will work out. You have to maintain, you have to support it.
So
So,
the
this is very
Access to
important.
liquid nitrogen.
Yes.
How will we
you get the
procure?
liquid nitrogen? How
There
will
are
you get the media? How will you
Yes.
confirm that cold chaining? So many points are there that they should be supported. Then only one lab. So,
So-
what I feel that if we will provide the transportation to the villagers or the rural person, then probably at the better district level, this can be thing. It cannot go to the villages.
So a new
at all.
word has come, transportation. When I was the president of Foxy in 2008, I was asked in a press conference, what will you do to reduce the maternal mortality? I said, build roads. They said, पागल है, build roads. Patient मर रहा है, build roads क्या हो? Sir, मरे हुए patient को ला पाओगे तभी तो बचा पाएंगे. So that is what it is. If you can bring the patient or take the specialist to the village, then only you will be. So the, uh or become a fellow Vriksha Commission societies. Yeah. So that's the challenges which we have. Indrani, back to you again.
Training.
Yeah, you wanted to add something?
Yeah, I was saying that even training of gynecologists to become an IVF expert, training of embryologist, that also needs to be seen. So like when you're looking at, when you want to provide all these services to tier 2 cities and villages, action has to happen at all levels, starting from the government, the policymakers, the thought process, because I mean, like Indira Gandhi, she thought of sending a satellite to the space in 1975 when we were struggling so much with hunger and garibi and family planning issues. Even as you know, we were graduates, we were so much concerned in PSM about family planning. Hum do hamare do was the slogan, and now look at it, the fertility rates have come down, and we are talking infertility. 30 years.
That needs
So
a
I think
change
every-
in the
yes.
education system as well, because
Absolutely.
the same books, we are also reading the same books, and they are still focusing on family planning where issues have evolved.
Yeah, issues have changed. So, you know, the change has to happen from the top right up to the bottom. And I don't think it's not doable. Of course, it's doable.
It is doable.
The thought process has
What
to
are the
change.
social stigmas, the religious beliefs, the family pressures? Do these affect fertility treatment?
Oh my God, this is all
Especially
about
small towns.
social.
Another big.
Infertility
So this
is
probably
more
the
of a
biggest problem
social
which we face,
issue.
taking this treatments to rural
Yes.
families,
Absolutely.
or even all families.
Yes, of
So
course.
what are these? Can you?
So these social things are a lot, like I said, it's looked upon as a curse and maybe a result of some bad karma which you have done in some past life or this life, and then the woman is is held responsible for getting a child. I'm not bringing the son-daughter issue in it. Not only a child, but to bear a son,
That's
because the son will take the family's name
that's-
forward. So that is such a pressure. So even after having 2 girls, couples want to come back. Thankfully, in my part of the country, I am from Kolkata, this is not much. Yeah, definitely there's more happiness on the birth of a son. But having a daughter, I mean, they are not unhappy, as I would say. So these are the issues, you know, and we all know that all these stem from more deeper issues like dowry and, you know, division of the family property,
so it's
etc.
a whole social
it's a
circle
whole
which is
so
involved.
infertility as such is more of a social problem and a medical problem. Yeah, the medical problem has just started to come up, and we are viewing it as more of a medical problem. But to change this mindset, I think we'll need another few years, and the dialogue has to go on. Public awareness has to increase.
So Dr. Keshav, do you think it's unnatural? What people say unnatural baby bahar banaya hai?
No.
Andar banna chahiye?
They do feel that it is unnatural, and it's not just in rural setups, it's also in cities like Agra, tier 2 cities. We face these patients every single day, and it's
No,
so
I hear
difficult.
this in Kolkata also,
It's so
which is a
difficult
metro.
to tell them that it's going to be your baby. You're going to carry the pregnancy. You can easily deliver normally or vaginally. I mean, there are so many myths that are related with infertility and so many misconceptions that half the time of the consultation is just trying to solve these issues rather than doing the medical treatment.
So when we opened our first IVF in 1996 in Agra, and this professor of surgery came to see the lab, and he said, "Where is the test tube in which the baby will grow?" I said, "The baby will grow in the mother's womb, not in the test tube." I mean, that was a professor of surgery of a medical college talking like that. So
I had a
that's-
patient, he came and said, "मुझे शीशी का बच्चा कराना है,
शीशी का बच्चा
शीशी वाला बच्चा कराना."
So,
So that's how it's perceived.
anything more you want to add on
So,
this social stigma?
actually-
कोई और story interesting?
नहीं interesting क्या means in the medical college how many pages of infertility we read? Only 4-5 pages. So the grassroots level, at the post graduation level or the MBBS level, we are not giving the proper education
So we
to
are
the
not-
doctors. So this is important, very much important that we should give this.
See,
Because they are not aware. That is the reason they ask them, where is the test tube and where is the professor level person.
I
can
remember
say.
when we passed out, infertility was just 2 pages in that book.
Yes.
And if you read Harrison in medicine, depression was only half page. Today, depression is 20 pages. 20.
But
So
unless
that's
and
how-
until
Gaurav,
then,
anything
unless
else?
and until medical colleges have IVF
So
units,
medical
they don't-
colleges should have
how
that.
will they end
So
up?
they
treating?
don't have this thing. So they,
Actually,
Yeah.
But
There
there
is-
is another problem of medical colleges. I will tell my experience about it. When I opened the IVF unit, which requires the full-time work, but they said you can't leave the labor room. You have to see the obstetric also. You have to do the cancer surgery also. You have to go for the teaching of MBBS at 8 o'clock morning also. Means so many things are there, and after that you have to work for IVF if you want, if you really
Then
keen
the
for this.
other units will not send the PGs to you to study.
And nobody will go for this. Nobody will go. You do yourself only.
Nobody will go from the other units.
Yes.
Only your unit.
So this was the problem.
So these are the major problems for teaching. Gaurav, anything you
Actually,
want to add on this point?
It's the stigma. I think that's the first thing.
Stigma.
IVF
blame.
पेशेंट्स कहते हैं कि हमने अगर किसी को बताया तो लोग पूछेंगे कि वो सब कुछ ठीक नहीं था क्या. तो ये जो स्टिग्मा है, सबसे पहले तो इसी को दूर करना जरूरी है फॉर अस टू रीच टू टू गो बियॉन्ड द सिटीज.
किसका बच्चा ले आई है? So that's
हमारा तो होगा ना सर.
So now let's come to technology. So if we cannot go to the villages, can we link the villages with technology, Dr. Keshav? You're talking a lot about AI and everything and telemedicine and
yes, it can be done. There are now systems.
So robotic IVFs in villages.
Yes,
you can sit from
robotic
here and do.
automated labs do exist in the Western world. Robotic ICSI exists in India as well. It's nothing new as of now. But the only challenge that I perceive is that again it's going to still be at the same cost. So we have access to telemedicine. You can do consultation sitting in a city. You can treat patients. You can write prescriptions. You will still need a doctor to do the pickup. You will need an embryologist to load the equipment. All of the other things can be done by the automated systems. You will need someone to do the transfer after that. But again, cost is going to be the biggest
human
challenge in all
element.
of this.
So Dr.
I
Indrani,
have to say something.
Dr. Indrani, I mean, in COVID times, that is when I used to talk about this. You give the vaginal probe to the patient, takes home, and right karo, left karo, you get the image of the ovaries. You titrate the dose and you monitor right.
Yes.
Setting it. So something like that.
Telemedicine, I think, can have a big role to play in this. And with the advent of AI, I'm sure we're going to have more and more tools which are going to help us in providing technical support in between the clinician and the patient and the embryology lab.
Every single thing can be done by
I
AI
think
now.
regarding cost, I have a point to make. I remember in the 90s, I was following up with an infertility clinic with Professor B.N. Chakravarti. And in those days also, the cost of an IVF cycle was around 2 lakhs. And that time the gold was 4,400 exactly. I can tell you the exact rate. The day I was told that the cost of IVF cycle is 2 lakhs, gold was 4,440 for 10 grams. I didn't have money, so I didn't buy. So now, even now it's 2 lakhs, 2.5 lakhs. But the gold is 95,000, if not 1 lakh. So if you look at it that way, the way inflation has affected our economy, the cost of IVF has not gone up, it has gone down incredibly. So we have to look at it that way. Everything is about perspective. Now if you think that 2 lakhs bahut zyada hai, then this. But if you change your perspective and if you look at like this, actually it has not gone up at all.
For the daughter's wedding, they'll buy so much gold. I mean, at 1 lakh also. But for an IVF cycle to have a child.
I always say कि जितना खर्चा अभी आप IVF में करने वाले हो, उससे ज़्यादा आप उसके फर्स्ट बर्थडे में कर दोगे.
I know.
Absolutely, that's true.
Yes, Dr. Sudha, you wanted
Baby
to
shower में हो जाए.
Telemedicine technology.
About the telemedicine, what I feel that it can go for the diagnosis, for the investigation, and probably if Madam said that the women can have their own vaginal probe and can show to the follicles. But finally, she has to come physically for the pickup. Embryologist has to come, and one day before keeping the media and to see the incubators, how they are working. So physical presence has to be there. So telemedicine is only up to the investigation and diagnosis.
And also in telemedicine right now, probably the rules are that you cannot prescribe medicines on WhatsApp or on. So that also has to be cleared. That also,
yes, very right.
Otherwise you cannot prescribe. You will be prescribing all types of drugs even narcotics on WhatsApp.
And
that
that's-
may lead
There
to
is
other
a
problems.
legal problem with
Legal
this.
That's also
yes.
where I think now, because AI is also coming into picture and AI based protocols are there, where you put in the ultrasound report for the first 3 or 4 days, and the rest of the 6-7 days protocol is
Protocol
given.
is decided by
No
some-
need for an ultrasound scan after that. We need to have regulations and rules for the use of such technology. We need to have some publications, and then only the country would be ready to actually use tech.
So as the panelists said, the telemedicine would give you a good idea about initial infertility screening, probably follow-up, but for IVF itself, they have to come back. So probably we could look for rural centers as a hybrid model, where they do that much there and then come.
Yeah,
come.
the hub and spoke model
Hub and spoke model is that
is what our country needs.
that is what it is. So what about enough embryologists? Dr. Keshav,
I think we have enough.
Now you
Honestly,
have-
I will-
No, not at all. We don't have
I
enough.
don't
No, but
think
we-
so.
How
No, we
many
don't have
ready-
enough.
Don't think
We
so,
still see
Dr.
embryologists
Keshav.
going to 10
let
centers.
me make my point. I think we have enough colleges now which are putting in master's degrees. There are hundreds, maybe almost 200 to 300 embryologists who are entering the workforce
We are in better
every
position.
every
yes.
single year, and we are doing about what let's say about 3
Well, I
lakh
think
cycles.
we don't have.
3 lakh cycles in a year, according to some of the papers and recent consensus is we have about 4,000 to 5,000 embryologists. That means that each embryologist is doing about 100 cycles a year, which is enough. So I
No,
feel
but these are all in the urban. How about rural? That is what we want.
no, but there are already 300, 400 who are entering every single
si-
year.
Every single
And
year.
when you
So that-
put, I will post once on LinkedIn that I'm hiring an embryologist, and I see hundreds, 200, 300 students who will
want to
send their CV, who have not been able to secure a job for the last 3 years, 4 years. The market is becoming very difficult. So I think this notion has to change, that we don't have enough workforce. We have enough workforce for the amount of work that we're doing. If we increase the work, yes, we'll need more people, but as of now, we've reached stagnation. And it's horrible. Honestly speaking, there is the training that's being done in colleges nowadays is something that needs to evolve, rather than getting more numbers, because we need more quality people.
So we need more
than
quality
quantity.
people and more people who are
Better trained
willing to
people.
go and serve in the road.
And
Yeah.
And I'll tell you one more thing, that the villages should have the facility to stay when we can't send the medical officer
So
or
that is,
interns for the village posting. How many embryologists and the IVF specialists will go there? So yes.
so quality, safety, ethical practice of going into the village. How about this ART Act affecting the villages? I think we'll all have to follow the ART Act. How about
Even in the urban,
Even-
how much ART Act is working?
You have
this
worked-
is also a question mark.
you have worked in
No,
the
I think
public
it's
sector
working
and
very
private
well.
sector. So how will they
There is lots of difference.
where
Lots
we
of
can where we can help or we
So-
can call
no. That's what I said initially. Also, the private sector also should be registered with government, and straightway the patient should walk in, and registered IVF centers should do, and they should get the reimbursement from that.
So
This
like
will be the fantastic.
like Gaurav
arrangement.
said, we should have a hub and spoke.
Yes.
So the
Also-
main center is in the center, and you have many
Yeah.
centers there, and they finally
Also, since you mentioned the PPP model, the government can do the setup capital expenditure, and the private sector can
Can
be
go and work
entrusted to go and run at the district level, where finding talent is still okay. Beyond that,
That's
it's
the way
really
forward.
difficult to find good trained talent.
So our final question to all of you, what do you see is a roadmap for equitable IVF across Bharat in the next 5 years or so by 2030? Are we going to see centers all over India, or are we going to see hub and scope model or public-private partnership? What do you think is going to happen in the future?
The first thing is the IVF is here to stay. And really long live IVF. It's a great technology, it's science. And in the next 10 years, I think we will have more of PPP models and more access to infertility services or across the country?
Keshav?
I think unless and until insurance plays a big part in this journey, it will not spread to the rural areas. So I think that's one thing that needs to be strengthened. If it happens, centers will open across India.
Dr. Sudha?
We
you-
should have a more training program
Training
for
is
the specialist. It is very much important that embryologists, andrologists, technicians, staff nurse, everybody
them.
should be trained for this. Then only they can work about it. Otherwise, no.
Yeah, totally agree with ma'am. If we are able to train people, then only we can open everywhere. Else, it will always remain concentrated to metro. Even if the demand is going to come, we will remain concentrated because of the lack of manpower. So the training is really the most
So,
important
ladies and
thing.
gentlemen, that was the one-line punchline from all of them about how we are looking at the IVF centers, and it was 11:47 on today, 25th July, 47 years back, that hope was born to millions and millions. Happy birthday, Louis Brown, wherever you are, and I know you are in a lot of functions which we communicated in the morning by WhatsApp to you. Happy birthday to you all. Happy birthday to all the Indians who led this, right from Subhash Mukherjee to all the 3,000, 4,000 centers we have. Thank you very much, panelists. Thank you, IHW, for bringing this, giving this opportunity.
Thank you so much.
Thank you.
And let's salute our pioneers, the Indian pioneers, which we are there. Thank you.
Thank you to all
Let's
our
have a-
speakers
let's
for
have a
that
picture
interesting conversation.
Come,
May
come,
I
we'll have a
please
picture.
invite Mr. Kamal to felicitate our guests.
Jaideep, take a picture.
Thank you so much.
No, no.
Thank you.
Ladies and gentlemen, can we have a continued round of applause for that interesting conversation?